Okay, I'm going to start. Good evening, colleagues and friends. Tonight, we're happy to welcome you to the Provident Clinical Society's virtual conference on COVID vaccine equity and confidence. A few words on the proceedings of this forum. We'll be using the Zoom platform in webinar mode. This session will be recorded for future reference. Speakers will be featured in the spotlight function and will be visible to you in the audience. Members of the audience will not be visible on the screens. To submit questions during the conference, we ask you to use the question and answer box, which you'll find in the Zoom toolbar at the bottom of the screens. The chat will be used for audience-to-audience communication and comments. Again, the questions to the panelists will not be taken from the chat, but rather from the QA box. Periodically, we'll be taking polls of the audience to gather demographic and other information to get an idea of who's joining us. Please respond once in the demographic polls and as indicated for the opinion polls. Now, the emphasis of tonight's meeting will be on equity, both its clinical and psychosocial ramifications. And in the interest of time, questions that do not specifically relate to these topics may be reassigned to Dr. Lawrence Melkner and myself, whereupon we'll attempt to redirect the questions to the questioner to the appropriate references. Again, I welcome you, and it is now my pleasure to introduce the president of the Provident Clinical Society, Dr. Donald Moore.
Good evening, everyone. Welcome again to the forum which follows the general meeting of the Provident Clinical Society. The Provident Clinical Society is the Brooklyn affiliate of the National Medical Association. We're delighted to have two sponsors for this particular event. One sponsor is Region 1 of the National Medical Association. The chair is Dr. Gary Butts, and the other sponsor for this event is the Medical Society of the County of Kings, an organization which I am a trustee and a long-standing member and a past president. So without any delay, I would like to introduce you to the president of the Medical Society of the County of Kings, Dr. Prasad Godavalli.
Good evening, everyone. Thank you, Donald. For those of you who do not know me in the audience, I'm the current president of the Medical Society of the County of Kings. I'm a general surgeon from New York Presbyterian Brooklyn Methodist Hospital and past president of the medical staff and a member of the board of trustees. I'm currently a member of the executive committee of the hospital. On behalf of the Medical Society of the County of Kings, I'm pleased to co-sponsor this event and participate in this conference, organized by Provident Clinical Society and co-sponsored by Region 1 of the National Medical Association. The differences in health status of different population groups and their healthcare outcomes are real and have significant social and economic costs, both to the individuals and to the society. Education or lack thereof, employment status, income level, gender, ethnicity, and lack of access have a marked influence and result in inequities in healthcare and outcomes and life expectancy. Lack of confidence due to misinformation, biases based on past bad experiences and religious beliefs should be eliminated by reaching out to and educating these vulnerable communities. Today's event is appropriately named COVID-19 Vaccine Confidence and Equity. We'll address these issues and hopefully help the public to boost their confidence and help the participating professionals to disseminate the information. Dr. Westerling, Dr. Blackstock, and Dr. Villanova are uniquely qualified to address these issues. The program director, Dr. Donald Moore, and the rest of the organizers deserve a great deal of credit for arranging this event, this timely event. Finally, I want to remind all of you today is March 30th, National Doctors Recognition Day. On behalf of the Medical Society of County of Kings, I want to wish all of you a very happy Doctors' Day and want to thank you for your dedication and for all the sacrifices you and your families made to fulfill your calling to serve the humanity during this pandemic. And thank you to everyone and the organizers and Donald for inviting me. And we are pleased to participate in this conference. Thank you.
Thank you, Dr. Godavalli. We have a very special treat for you. We will be joined in a few moments by our own representative, Congresswoman Yvette Clarke. Until I'm promoting her already to a doctor. Until Representative Clarke joins us, I would like to just make some opening comments on that will sort of give a certain context and maybe a pretext to why we're actually having this conference, this particular webinar. Obviously, if everything was normal for African Americans in Brooklyn, this conference would have a different name and we would be doing something else this evening. With COVID-19 pandemic still raging in Brooklyn, New York, the United States, and the world, it is still unclear, certainly unclear to me, how much impact vaccines will have on ending the pandemic. Vaccine production, distribution, and administration are still behind what it will take to shorten the pandemic curves worldwide and the epidemic curves nationally. And now, to make things even worse, we have all these variants threatening to decrease the effectiveness of our vaccine program. Nonetheless, we welcome the COVID-19 vaccine to our preventive armamentarium. According to news reports, vaccines have been performing as well in the real world as they did in the phase 3 trials. And we look forward to their biological licensing soon. In the interim though, it's important to remember that no vaccine is approved for prevention of COVID-19. The current biological products that are being distributed under emergency use authorization are experimental and, like most other vaccines, have known short-term side effects. They also have the potential for myriad unknown short-term and long-term side effects, depending on the platform that is being used. However, COVID-19 vaccines are likely to be an important factor in mitigating additional pandemic waves and limiting the incidence and prevalence of COVID-19 post-pandemic. In 1989, the CDC sponsored a Kaiser Permanente Los Angeles County measles vaccine study on infants, where the experimental Edmonston Zagreb measles vaccine was administered to Black and poor infants. The mothers of the children were not informed that the vaccine was experimental. Later, this vaccine was believed to cause death and morbidity in African and Haitian children, resulting in its discontinuation worldwide. 5 years after the experiment, Dr. David Satcher, then the director of the CDC, admitted that a mistake was made and he apologized. In addition, there is an abundance of instances where medicine and the healthcare delivery system has exploited the Black body for experimental and scientific inquiry. I refer to the United States Public Health Tuskegee experiment, Johns Hopkins management of HeLa cells of Henrietta Lacks, J. Marion Sims surgeries, repeated surgeries on Anarcha and other slaves, and the excessive use of Negroes for autopsy and dangerous experiments during Jim Crow and slavery times. These practices are rooted in scientific racism and medical apartheid. And as these inequities still exist, similar atrocities are likely to recur. Since the experimental vaccines are being distributed widely at this time, it is likely that we will lose some ability to gather necessary information about vaccine efficacy and safety in the future, as less people will be available for clinical trials. Therefore, we should monitor those receiving the vaccines as if they are in a phase 3 trial. They should at least receive PCR swabbing and serology blood testing. Also, they should be monitored actively in addition to the passive CDC vaccine adverse events reporting system. It will soon become apparent whether the vaccines will be as effective and safe in the real world as in the phase 3 trials. We must get updated information from the pharmaceutical companies. The last time we got information was about 3 months ago. We really need updated information. And they, the pharmaceutical companies, should apply for biological licensing so that the population vaccinated can benefit from injury compensation and other legal and public health protections usually afforded to a licensed vaccine. Finally, it is relatively easy, and it is the duty of a physician to inform a patient on what treatments are standard of care and what treatments are experimental. So, especially because the vaccines are not licensed, the population should be free to choose if they want to take the vaccine. Incidentally, my patients have most of them chosen to take the vaccine, despite the fact that we have these types of discussions. Employees, incarcerated people, and other individuals with limited freedom of choice should not be mandated to take an unlicensed biological product. Also, vaccination status should not be used as privilege or a passport, particularly since there are no licensed COVID-19 vaccines at this time, and the effectiveness of the vaccines in the real world have not been determined. So this is my take as an individual. However, it should not only be my take, and this is why we're having this conference. We have put together what I consider the brightest and best of the brightest and best. You know, physicians, we have a talk amongst ourselves that, I guess it has got to our heads that maybe we are the brightest and best. But believe me, what you're about to experience tonight is knowledge imparted by the best and brightest. So I am not sure if the Congresswoman has joined. Can somebody indicate that to me? If not, I will move on to introducing our moderators. Okay, so I would like to introduce two individuals that I think are outstanding physicians, outstanding teachers, and in my mind, just outstanding people. The first of the two is my good friend and colleague, Dr. Monica Sweeney. She is a product of Downstate Medical School and a product of the Mailman School of Public Health at Columbia University. Now, when she became president of the Medical Society of the County of Kings, I just met her not too long before, and she says, Donald, you need to help me with this organization. And I joined her, and I hopefully supported her during that time. But more importantly, she supported me for the rest of the time that I was a member and have been a member of the Medical Society of the County of Kings. Not only is she a professor, a former, I guess the word is assistant commissioner of the Bureau of HIV/AIDS for the New York City Department of Health and Mental Health, but she is also a family woman. She spends, I know that, a lot of time with her family and as a mentor and a matriarch. The other moderator that I'd like to introduce to you is Dr. Camille Clear. My memory of Dr. Clear goes way back many years ago. I was walking in the street protesting something, and there was this woman holding a banner that said the National Medical Association. And I said, oh, I know that organization. And I carried the banner with Camille for a few blocks and wondered, how could she carry this banner for so long? Well, Camille really ended up in Brooklyn, like so many most important people. She is now chair and professor of the Department of Obstetrics and Gynecology at SUNY Downstate Health Science University College of Medicine. And she's a professor at the School of Public Health. She received her medical degree from Einstein in the Bronx, a place where I grew up. And her residency was done at the State University in Buffalo. She also earned a Master's of Public Health in Health Policy Management. So, as you could see, well, I should also say that Camille is a leader nationally in the National Medical Association and certainly guides me as president of Provident on basically how to behave appropriately as an affiliate of the National Medical Association. So I'm indebted to these two female physicians for their wisdom, and you will agree with me by the end of this show that you will also be indebted to them for their skillful management and wealth of knowledge that they're about to impart to you. So at this point, I'm going to ask Dr. Camille Clear to introduce our next speaker.
So thank you so much, Dr. Moore, and I believe Representative Clark is on, and so if I would love to divert to her since she represents the district where I currently serve, and so if Representative Clark wants to make some words, also my soror, so I would be remiss if I didn't recognize her and all the good work she's done for us in Brooklyn. So Representative Clark, I would appreciate you starting us off. Thank you so much.
Absolutely. Camille, thank you, soror. I appreciate you yielding just so that I can bring a few words, because I am just so proud of the work of Dr. Donald Moore and the team, as I like to call them. You all have been a respite in the eye of the storm, and the work that you're doing to educate, inform, formulate, and strategize around the health needs of the most vulnerable amongst us is God's work. And during this Holy Week, it is so fitting that you would take on the subject matter of vaccination. Good evening, everyone. I'm Congresswoman Yvette D. Clarke, and I proudly represent New York's 9th Congressional District, better known as Central and South Brooklyn. And I'm proud to be here with you today, albeit virtually. Let me thank the Provident Clinical Society the Region 1 National Medical Association, the Medical Society of the County of Kings, and the panel of very distinguished speakers, medical professionals, all that have joined us this evening. You know, the equitable distribution of vaccines has to be a primary focus of the government at the local, state, and federal levels. Because simply put, the equitable distribution of this vaccine will save lives. And the lack of equity associated with this vaccine will and has, in many cases, caused an unnecessary loss of life. We cannot allow this to continue. This vaccine is how we get back to a way of life in a post-COVID era, and what that looks like and how we shape the normalcy as a result of that will be determined by what we do now. We have to trust the science. It's how to see our families again. It's how we reopen our small businesses. It's how we get our children back into full-time educational institutions. It's how we get back our lives. Let me also say that my octogenarian parents and I have all been vaccinated with both doses. We are fine. We did not grow horns. I don't feel any aches and pains. I'm still traveling between here and Washington, D.C. and feeling fine. However, there's a growing mistrust and skepticism associated with vaccination, particularly in communities of color, which are hardest hit, and we must combat this. We must not adopt this harmful mindset. You know, I can go into deeper detail. Just to digress a moment. When I think about those who have come from tropical climates or come from other nations, the vaccination regime in those countries are fast and furious. There's always some tropical disease that has to be vaccinated against. I myself have been vaccinated for many other common diseases, what had been common diseases, but are now essentially defunct. We have to be bold enough, brave enough, trust in the science enough to step into the 21st century. And I think you'll hear a lot about how these vaccines were developed and the soundness of the science behind it. We are communities of color, and we cannot afford to continue with a frame of mind of victimization. We are losing precious lives at an alarming rate, and the only way forward is through vaccination, social distancing, and an unrelenting commitment to doing whatever it takes to see an end to this virus. COVID-19 has ravaged our community and put the very best of us in unimaginable positions. I have fought and advocated for our district to ensure that we have the resources necessary to give our community the assistance we so desperately need. And I want you to know that I will never stop fighting on behalf of the 9th Congressional District and by extension, our nation. For more updates on the vaccinations, be sure to subscribe to my newsletter at clark.house.gov/newsletter. You can also follow me on Facebook, Instagram, and Twitter at Rep. Yvette Clark. And be sure to tune in tomorrow night on my Facebook, Twitter, or YouTube for my town hall on the American Rescue Plan, one of the most innovative, transformative legislative measures since the passage of Social Security. Additionally, you can find all the information and links with how to access that information through my newsletter on the ARP. So to everyone this evening, let me thank our dedicated medical professionals, epidemiologists, and everyone within the medical field who has made it possible for us to reach this point in the midst of this ravaging pandemic. And thank you for lending your expertise to navigating our people through a very harrowing time. Stay safe, stay healthy, stay strong, stay blessed. Happy Easter for those who celebrate, a blessed Passover for those who celebrate, and most of all, wear your mask and get the vaccine when your time comes. With that, Mr. President, I yield back.
Thank you. Wonderful, wonderful speech. Thank you. Encouragement.
Thank you. Thank you so much, Congresswoman Clark, and really appreciate your words. And I will be visiting you in your local office when time allows. So thank you so much for hearing from you. And you mentioned our local leadership. So at this time, I'd like to introduce our first speaker for this evening, someone I consider a friend, a colleague, and one of the people responsible for getting me here to Brooklyn, my colleague, Dr. Torian Easterling. He has an extensive leadership background, but just a short few brief words. Dr. Easterling currently serves as the first Deputy Commissioner and the inaugural Chief Equity Officer. He served as the Deputy Commissioner of the Center for Health Equity and Community Wellness at the Health Department in New York City. During his time as Deputy Commissioner, he led the restructuring of the Center of Health Equity and Community Wellness and has led the agency's equity plan in response to the COVID-19 pandemic. He's a family physician by training and really has been a colleague and really a source of strength and support during these challenging times. So great to introduce my colleague, Dr. Easterling. He's been a mentor to many and has done a lot of work regarding Black men in medicine and is an example for all of us. So Dr. Easterling, thank you so much.
Thank you so much, Dr. Clear, for the kind words. Thank you to Dr. Moore, Dr. Smith, Dr. Sweeney, for your leadership with Provident Medical Society, and certainly the leadership of both the Medical Society of the County of Kings, the Physician National Health Program. Certainly really important that we are showing collective action and making sure that we are getting information out, addressing questions, and supporting our providers and our healthcare officials. And certainly to the esteemed panel, Dr. Blackstock, Dr. Villanueva, certainly it is a pleasure to be on a panel with you. Certainly always great to see Congresswoman Clark. And so with that, I'll try to just sum it up, at least my remarks, in sort of three areas. I think that we certainly have to acknowledge, a lot of the work that has been going on, and certainly sort of thinking about BC before COVID. The conversation around addressing and dismantling structural racism has been part of the work of the Department of Health, and recognizing that structural racism is the root of a lot of the poor health outcomes that we see in New York City. And has been the work of the agency to sort of think about reinvestment. And I think it's important to sort of start there because, we can turn back to some of the historical injustices, but I think it's also important to have a conversation, root this in some of the contemporary injustices in healthcare and how bias shows up in our system, and really begin to help draw the conclusion, the connections to how our work has to continue to push forward once we move past this pandemic to make sure that we're still having these conversations and building a public health system that's going to really support our communities. And so, I think, how interesting we are at this time at the start of a trial for the person who is responsible for the death of George Floyd right now, when in 2014 into 2015, we were having the very same conversations as the trial was wrapping up for the person who murdered Eric Garner. And so we're having these conversations because the intersections of poor housing, inadequate food sources, overcriminalization in Black and Brown communities, lack of healthcare access, is all summing up into how we understand policies and practices have led to these health outcomes. And so now we're having a conversation and we're seeing it with clearer eyes during this pandemic. And certainly, so we should not be too surprised how the vaccines rolled out nationwide. The data has shaped out who has access, how are we supporting those to really feel confident about taking the vaccine. So I do think we have to keep our foot on the gas here. Certainly, as we have gone through this year, it's challenging and troubling. During the pandemic, sort of sharing data, thinking about the resources of testing, contact tracing, supporting communities, and making sure that organizations are invested in not just mutual aid societies, but critical organizations that have been doing work from doulas to thinking about social services, community health workers, peer navigators, resourcing them in the way that they can, one, continue the critical work that they've been doing, but also supporting individuals through, through this pandemic, has been ways in which we can think about, integrating an anti-racist public health practice. And I think that there are certainly more that needs to be done. And I think that there are more investments that need to be made. We're certainly talking about a vaccine, but we have to keep the vaccine in the context of it is a tool. And that is the conversation that I think we have to continue to ground it in, because the vaccines are certainly a tool to get us to having the next conversation about how do we continue to press forward with dismantling structures that have perpetuated oppression in healthcare systems. And I think that certainly this group and many others have been at the center of those conversations, and really making sure that we are thinking about the type of partnerships, thinking about the type of investments, but also keeping our advocacy very clear of what those recommendations are. And so I think it's been a process that we have to continue to press forward on, and I look forward to the conversation today. And so to the third point, right? And so thinking about before COVID, how we continue to support our vaccine rollout, but making sure that our vaccine rollout is also seen as a tool, as a step forward. I think the third part is really continuing to have this conversation about reimagining a public health system that centers equity, that centers racial justice, that centers healing, all forms of therapy, but also thinks about communities in a way that we have not done so in the past. That doesn't just center around healthcare systems, but really broaden it to think about different forms of health systems, and thinking about how community plays a part in that. And I think that those are the conversations that, in addition to our vaccines, really give our communities a chance to build trustworthiness, because we are centered in sort of the historical and contemporary injustices, right? Much more than just talking and naming about the ones that had hit the newspapers, but I mean the names of people who go untold, and names that we have not heard about, but we know have been impacted by decisions, by practices and policies. And so thinking about what are those trainings, how do we recreate safe practices in healthcare systems, how do we ensure that housing and food systems and structures are really supporting our communities. And I think that gives us an opportunity to really show up in a way in communities that's different than just saying, take the vaccine. And I think that also empowers providers to show up differently, when you can have a much broader conversation beyond just vaccines, but also thinking about broader ways that we can support our communities to good health. And I think we have to have that dialogue, and certainly be in a place of beautiful struggle, but also be willing to be bold and courageous in our leadership to move past that. So I'm really honored to be joining you all this evening. I'll pause there. I look forward to the question and answer.
You're on mute, Dr. Sweeney.
Yes. Yes, we can hear you.
Can you hear me now?
Yes, we can.
Okay. I want to thank Dr. Easterlin for those remarks, and we will get some other information from him as we get into the Q&A. It is my distinct pleasure to introduce Dr. Uche Blackstock. Dr. Blackstock is a graduate, a Harvard-trained physician. There are many, it's posted so that you can read that part of it. I want to talk about the fact that she's also the founder and CEO of Advancing Health Equity. And the last time I actually saw Dr. Blackstock and her sister, Dr. Blackstock, was at a special program in honor of their mother, where I got to speak about their trailblazing mother. But they continue very much in the same vein as their mother in terms of being trailblazers. And I don't know how many of you have seen it or seen her, but Dr. Uche Blackstock is all over the media. The last time I personally saw it was when she was on MSNBC, but this is a regular occurrence, not only there, but she has been a Yahoo News medical contributor and appears regularly on cable and broadcast programming. And it is my distinct pleasure to introduce Dr. Blackstock to the forum.
Thank you so much. Thank you so much, Dr. Sweeney. I'm very excited to be here. Also of note, our mother, Dr. Dale Blackstock, was a former president of Provident Clinical Society, and Oni and I attended many Provident clinical meetings as children. And so I'm very honored to be serving on this panel today with the other panelists and with you all in the audience. So I just have a few comments just to talk about. And really it's just, I was asked to just sort of frame sort of how systemic racism has impacted how the pandemic has disproportionately hit our communities. And one thing I wanted to note, and it's something that I know that you all are aware of, is that many of these racial health inequities were present even before the pandemic, and the pandemic just exposed them. But just some that I want to throw out to you are that Black men have the shortest life expectancy. And we saw that even in early 2020, because of the pandemic, they're already short life expectancy, shortened by another 3 years. Black infants have the highest infant mortality rates and the shortest, and the lowest birth weights. And then we know the data around Black women with the highest maternal mortality rates in the US, 3 to 4 times that of white women. And this trend persists despite socioeconomic status and level of formal education. And so what we know is even the chronic stress of living with daily racism results in the weathering effect described by Professor Arlene Geronimus, the premature physiologic aging of Black bodies. And so, living in this country has essentially made Black Americans sick. And as we've seen over the last year, we've witnessed a crisis layered upon another crisis as Black communities across this country have borne the highest burden of the coronavirus. And it was my own experience working in urgent care during this time, working at several urgent care sites in central Brooklyn, that literally within those 2 weeks in mid-March, I saw my patient population just shift significantly from racially, socioeconomically diverse to mostly Black and brown New Yorkers. When I talked to them, many of them were essential workers and service workers, all coming in with COVID symptoms. I even had said to our staff, I said, do you notice not all of our patients look like us? And this was before any of the racial and ethnic demographic data came out. And I was very concerned, and I took that opportunity to actually pen an op-ed that would eventually be published in Scientific American, and this was before March 30th. But I knew that and I'm sure like many others who are concerned deeply about racial health inequities, that this pandemic was going to disproportionately impact us. And, you know, I've been practicing for 15 years. I've worked in emergency departments with the sickest patients, and I've never been so scared to go to work as I was at that time. I remember in particular an elderly Black man who came in with shortness of breath and fever. His oxygen saturation was quite low in the mid 80s, and he lived by himself. I was very worried about him, and I actually wanted to have him transported to the closest ER, but he told me he would not go, he didn't want to die in the ER, and that he didn't think that he would get good care there, and that he felt safer at home. And so I had a lot of conversations like that with our patients who, you know, did not feel safe seeking care. And so obviously that's a problem, and it's not uncommon. And as Dr. Easterling mentioned, it's based on both historical and ongoing discrimination that Black patients face in healthcare settings. And right now I can't even get the image of Dr. Susan Moore out of my head. You know, she was the Black family medicine physician in Indianapolis who posted a video on Facebook on what she recognized as unequal and bad healthcare treatment while in the hospital with COVID-19. Ultimately, she died a few weeks later in December, and that video has been viewed by thousands. And in that video, she heartbreakingly pleads for her physician to help her. And you know, myself and three of my other Black women colleagues, physician colleagues, we actually penned an op-ed in the Washington Post about her. And I just want to share some words that we wrote about her. Like in the video prior to her premature death, Dr. Moore shines a light on the experience of racism in healthcare, begging for the standard COVID treatment for her disease severity, not being thoroughly examined. He didn't listen to my lungs or touch me, receiving outright refusals in care and then delays for medications, and an overall lack of affirmation of her humanity, dignity, and agency. And so what we've seen is that, you know, systemic racism, interpersonal racism has essentially placed Black people in this country at risk for illness and death, especially in this pandemic. And it's been a key driving force behind the factors that determine individuals and the community's health outcomes. And so I think in this moment, we have an opportunity to intentionally and explicitly acknowledge unjustified past and ongoing wrongs to Black communities, engage and center with them, and rebuild them equitably. Thank you.
Thank you so much, Dr. Blackstock, for your excellent words and wisdom that you've imparted from the beginning. We're celebrating a year that we've experienced this pandemic. You mentioned a couple things that hopefully one of my colleagues will now speak to, Dr. Rachel Villanueva, who I'll introduce next. And just for the audience, we do have some polls that are going up in between to really identify who we have as participants in this meeting. So please go ahead and answer that. But to this moment, you spoke about a couple of things such as disparities in maternal mortality, and my colleague and friend, all are my friends who are speaking on this panel, Dr. Rachel Villanueva will speak to us next. She currently serves as the clinical assistant professor of obstetrics and gynecology at the NYU Grossman School of Medicine. She earned her bachelor's of science in biology at Yale University and medical degree cum laude from the Yale School of Medicine. She's board certified OBGYN and practices in New York City. She's an advocate, a women's health expert, and has held multiple positions in the National Medical Association. Most importantly, currently serves as the president-elect of the NMA, and as the National Medical Association is experiencing its 125th year anniversary, hopefully she can share some light into what the NMA has been doing to address this vaccine confidence and equity that we've heard about, and perhaps share some wisdom regarding her experience as an OBGYN and the vaccine for her patients. So Dr. Villanueva, lovely to hear from you.
Thank you, and good evening. Thank you, Dr. Claire. Thank you, Dr. Moore, Provident, and the Medical Society of the County of Kings for this invitation. I'm bringing greetings, obviously, on behalf of the national organization and President McDougall. It's really an honor to speak in front of this group, and I think because There's so many friends and colleagues and experts here. It makes me quite nervous, to be honest. But it's really an honor to be part of this panel, a group of people that really trying to move the needle forward in the space of health equity. And so I'm just going to speak a little bit about NMA's history. And so as Dr. Easterling and Dr. Blackstock so thoughtfully and candidly outlined, COVID-19 has really highlighted disparities that we knew existed in our society, but none more important than those in healthcare. And structural racism, systemic and pervasive biases have all been implicated in the disparate outcomes for communities of color. And to all of us on this webinar, that these things are probably not new or surprising, or that COVID-19 really didn't need to highlight them for us. These disparities really fueled from an inequitable system was where the NMA was actually born, and why the NMA was founded. So founded in 1895, it's the largest professional and scientific organization, not only representing us as physicians of color, but also our patients who largely remain underserved and under-resourced. And the disparities of today are firmly rooted in the segregation and in the systemic racism that are not so distant past. And it's certainly ironic and sad, and really gives us all pause that in 2021, as their current efforts to restrict voting rights, it harkens back to the Jim Crow laws, where that were right in the middle of where an NMA was started. And during the segregated time, these exclusive laws affected all aspects of African Americans' life, from education to housing, and certainly to medical care. Separate did not certainly mean equal, and really in healthcare generally meant something that was substandard for these individuals. Black physicians were not allowed to have admitting privileges to hospitals, couldn't be part of medical societies to educate themselves. And so physicians found a need to not only educate themselves, but to take care of their own patients. And so they first started by having local state societies. MedChi in Washington, D.C., for those of you who are familiar, was the first of these that was started in 1884. And they were created all over the country. And ultimately, the founders of NMA decided they needed a more national platform. And so they created the National Association of Colored Physicians, Dentists, and Pharmacists, because there really weren't enough Black physicians to have their own society at the time. Eventually, this name was changed to the National Medical Association in 1903. They would advocate for better health practices and policies for Black patients, and also for to address racial discrimination in the medical profession itself. And obviously, these are at the hallmark and heart of the NMA today, and we are committed wholeheartedly to these efforts. And since its inception, the NMA remains the voice of African American physicians for health and equity. So in the spirit of this commitment, the NMA COVID-19 Task Force on Vaccine and Therapeutics came out of policy that was passed in our 2020 House of Delegates to really address some of the concerns that we knew would come from our patients based on historical and lived experiences, and then just based on the fact that this was something new. So over the past several months, this task force made up of experts met with researchers from Pfizer and Moderna, J&J, Janssen, met with the FDA, and also with AstraZeneca. And they really focused not only upon safety in general of the vaccine, but particularly questions that our patients would have. Were there increased risks for patients of color? were there patients of color even part of these clinical trials? And that's a question that I often get from my own patients. We discuss whether chronic diseases, diseases that specifically impact our population, sickle cell and lupus, were these looked at in the clinical trials. And ultimately, the task force supported the emergency use authorization of the 3 current vaccines. I think the task force also really asked for them to look to all of the organizations that we talk to, all of the companies, that they advocate for building equity into distribution plans of the vaccine. And not that they solely had that in mind, but that was an important issue for us. And as we discuss trusted messengers and why we felt that the task force needed to be created, we can't do so without really looking back at constructs that existed in the time of the NMA that significantly impacted and continue to impact our workforce diversity. And we know that biases in healthcare providers affect not only the type of care that patients and individuals in our community get, but even the ability or the desire for patients to come and seek medical care. If they don't feel that they're heard, if they don't feel that the provider really understands what they are, their experiences, they're not going to come to the doctor and they're not going to get care. And we know that competent physicians who understand our communities are desperately needed. Unfortunately, medical schools were systemically destroyed, really, in the 1900s by the racism that existed, by lack of funding and lack of resources. I think there was none more destructive than the Flexner report. And under this report, the number of medical schools in the United States drastically decreased, and it was disproportionately affected Black hospitals and Black medical schools. And in the end, by 1923, there were only 2 Black medical schools that continued to continued to exist, Howard and Meharry. And I think, and over 100 years later, now the ripple effect is still felt in the lack of diversity and the lack of number of physicians that are being trained or have the opportunity to be trained. I think prior to the Flexner report, there were probably as many as 14 Black medical colleges that were training physicians of color to treat communities of color. In 1920, 2.5% of physicians were African-American, and it's sad and shocking, and maybe not so shocking, that number is only 5% today. So the NMA continues to work collaboratively with many organizations, many that are probably on this call, locally and nationally. We work with the AARP, we work with Black Coalition Against COVID, the Urban League, Rainbow Push Coalition, all really trying to promote confidence. Initially, it was really to educate around COVID-19, but now it's to promote confidence around the vaccine so that our members will actually, or communities will actually take the vaccine. Locally in New York, we really have been working collaboratively, and I can attest to the fact that Dr. Easterling has been doing an outstanding job in getting the city and community and different partners involved. I know Dr. Blackstock will agree with me that probably half of my weekly Zoom calls are from Dr. Easterling, some task force, some group, but it really is, it's making a difference, and this is really what we need. So finally, in the fight to reduce disparities and barriers to access and champion health equity, the NMA remains as committed as it was 125 years ago when it was founded. It's so important that we come together in forums such as this to collaborate as physicians, as healthcare professionals, as advocates, as experts, to share best practices, to educate our communities, to bring these issues to light, holding a magnifying glass to our broken health system, and to hold the individuals accountable that created this system, and to dismantle the systems that perpetuate these disparities that exist within it. So thank you again for this opportunity to discuss a little bit about an organization that is so very important to many of us on this call, and personally to me. Thank you.
Thank you so much, Dr. Villanueva, for that wonderful perspective going back over the history of the NMA, especially mentioning the Flexner report, which still reverberates, the results of which. And we are now to the point of Q&A. Just to reiterate to the listeners, there will not be any questions taken from the chat. The questions will only be taken from the Q&A. And at this point, I would like to ask Larry, are there any questions? Dr. Melniker, are there any questions in Q&A? Dr.
Yes, thank you so much. Representative Clark is posting a question right now, which states, with the massive influx of federal support, Medicaid expansion, provision for free vaccines, direct support to states and municipalities, how do we maximize the massive federal funding support to stand up a robust public health infrastructure?
I think that's a great question for Dr. Easterling, if he felt that he could take that from a public health perspective and DOH perspective, if he felt comfortable with that question. Thanks, Congresswoman Clark.
Yeah, no, really important question. Thank you so much, Congresswoman Clark. So we're certainly paying attention to this administration and the decisions that are being made. Some of the things that we are already paying attention to are the ways in which we can really support our federally qualified health centers, because really important for us. So just to step back, when we're thinking about our equity goals, we're really thinking about the populations that are important, right? And so looking at age, race, ethnicity, and also place, right? Thinking about those neighborhoods and really thinking about the facilities that are going to really support those populations. We know that our federally qualified health centers have been really important. And broadly, we know that our physicians play a really important role in connecting individuals, particularly in BIPOC communities, to getting the vaccine. One, through messaging, and two, also just in modeling, good healthy behavior. So supporting our federally qualified health centers has been key. We've already heard the announcement that more doses, millions of doses, are going to our federally qualified health centers. And not only doses are important, but we also needed to really make sure that we were leveraging funding to also expand their capacity to absorb those doses. And so you have to think about staffing and also administrative resources that are needed. And so we are doing that by supporting our federally qualified health centers across this city to make sure that they can absorb those doses and really get those into the arms of New Yorkers. And then I think the other really important role, and I talked about sort of reinvesting in our public health workforce. And so we know that we needed to really have an expansive contact tracing effort. And now we know that we really need a really expansive vaccine core as well. And so how are we thinking about leveraging those staff across the city to really support our vaccine sites, not just thinking about these max vac sites, but also thinking about the pop-up sites that not only need individuals who you need to vaccinate, but also you have a lot of supportive staff, flow monitors, medical greeters, and the like, and really making sure that you have a really robust system. And so staffing has been really important, and being able to hire from the communities that have been disproportionately impacted has really been really important. And so not just thinking about it for the here and now, but how these public health workforce members can also step into future roles, whether they want to go into the public health department or into a healthcare system or working into a community-based organization. So really lining up these workers, this workforce, to really be prepared for future health roles. And that could be community health workers, doulas, and peers as well. And I think really reinvesting into those type of infrastructure is really important. And I know, and I continue to hear this week after week through our community advisory board and all of our community partners. It's really about how are we leveraging this funding to really support our community-based organizations. We're leveraging our community-based organizations to get the word out, to do messaging, to do town halls, but also we're leveraging our community-based organizations to help schedule appointments. And oftentimes these organizations are not resourced well to be able to schedule those appointments, to identify individuals who want to be vaccinated, get them an appointment, follow up with them, making sure that they're completing those appointments. So how are we really, supporting these organizations, these community-based organizations across the city who are doing critical work, from maternal health to also addressing food insecurity, housing insecurity, while also supporting our vaccine rollout. And so we've certainly made some strides, but I think this is a way that we can think about prevention and not always thinking about how these dollars flow through our healthcare system. And I think this is the way in which we can really expand our public health infrastructure. And I think that this is a model for us to continue to think about. And I know that we'll be hearing some additional decisions from the federal government through Center for Medicaid and Medicare. So really, really excited about some of the discussions that are happening.
Thank you, Dr. Easterlin. One of the attendees asked the question, how can we get nurses? Many nurses are refusing vaccines. They're on the front lines. Their risk is high. How can we get nurses to accept the vaccine? We, as professionals in the community, what can we do? And does anyone have any data that you can? I have many case studies, but does anyone, either of the panelists, have data about the number of nurses refusing vaccines?
I don't have the data offhand, but I've been hearing, I've seen it, and certainly it is supported that we are seeing physicians who are being vaccinated, and we're seeing nurses who are not accepting the vaccine or readily accepting the vaccine. I think that, we have to really get at the heart of the matter. We got to have the conversations, and I know the healthcare systems are having these conversations. I know that unions are having these conversations. We've been in many discussions with 1199, and many other unions as well. And not to forget, not just our nurses, but our home health aides, home care workers are all important in really thinking about how we're addressing vaccine confidence. We know that it's not an access issue, because when you think about the access points that our nurses have, they really just need to show up to work, and there are sites that are right there at their institutions. And so, I know that, we've been using town halls, vaccine champions, and really, I think that there's a conversation that needs to be had about how we're really supporting going forward. How are we doing workforce protection? How are we, thinking about really supporting, nurses to make sure they get vaccinated and have paid time off? I think all of these different strategies are really important in having this conversation.
I think
Dr. Blackstock, I don't know if you wanted to add anything.
Actually, I think Dr. Claire was about to say something, and then I can speak after her.
Oh, Dr. Villanueva, I'm sorry, go ahead.
Oh, Dr. Villanueva, sorry.
Yeah, no problem. I was just gonna say, I think the one thing that we have to remember is that nurses, other health professionals are people. And I think they all still have the same concerns and reservations as anybody would. Even, I think we have this unnatural expectation of ourselves and other health professionals that they shouldn't have the same concerns. And I think it just really goes to show that we do, right? And that we need to show as much sensitivity to our own colleagues as we do to the patients and people in our communities, to reassure them of the safety of the vaccine. Obviously, they understand the necessity and they're on the front lines. They see how what could happen if they get COVID. So I think they understand very well. So I think it's really telling when individuals who are in that situation are still not, concerned about taking the vaccine. So I think it's just, I think we have to do what we're doing now and continue to educate and reassure our fellow colleagues.
Yeah, I agree with Dr. Easterling and Dr. Villanueva. I think that it shouldn't be surprising that, that there are people who work in healthcare that don't have concerns about taking the vaccine. I mean, especially when you're looking at, Black folks who work in healthcare. I mean, racism has essentially traumatized us, right? And institutions have not always been trustworthy, right? And still aren't. And so we have to realize what we're asking people. We're asking people to trust systems that have not treated them well and still don't treat them well. And so I think that we also have to appreciate the work that it's going to go into those conversations, that it's not just one conversation or two conversations, and that it really, there's an education piece, but there's also a discussion piece. We need to, make sure we're understanding what people's concerns are. What do they know? What don't they know about the vaccine, right? How can we help support them? I think a lot of the points that Dr. Easterling mentioned about ensuring that we're giving people, a day off after they get the vaccine, or just supporting them around getting the vaccine is incredibly important. But this is not surprising at all to see the low uptake among our nurses and among home health aides, right? Because they are living in this society as Black people. And we know the trauma, right? We see a trial going on right now of a Black man brutally murdered in front of community members. And so it's not going to be one conversation, it's going to be multiple conversations. And I think many of them will probably come over to the other side with time, but it's also a lot to process. There is a mountain of information about these vaccines, and people have very valid and just questions about the vaccines. And so we need to give people the time to process the information to make decisions for themselves.
I think there's going to be a poll that's going to come up right now about attitudes regarding the vaccine. So as we continue this conversation, please feel free to answer these poll questions as we talk about, what we can do to have these questions addressed. I had a question, if it's oh, go ahead, Dr. Sweeney.
No, go right ahead. I'm answering the poll.
No. Yeah, I was just thinking when Dr. Easterling was talking about the social determinants of health that he referred to and the public health response and addressing those issues in addition to the equity piece that we're talking about. I don't know if you wanted to expand a little bit about that from an infrastructure perspective as a public health practitioner as myself as well. I'm working in Central Brooklyn now, and really that's at the heart of what we do every day within my own department. And thanks again to Congresswoman Clark for her hard work that she's done for us in Central Brooklyn. So just wanted to hear a little bit more about your perspectives from the infrastructure and social determinants piece, if you felt to share.
Yeah, no, I appreciate the opportunity. Well, I think thinking about this in a number of different ways. So we understand, I've been hearing more and more about practices and policies. And so I think that there's an opportunity for us to continue this conversation about how we are really doing an analysis of practices and policies, and whether or not they are perpetuating oppression and discrimination. And I think we can do that both at sort of at a macro level, but we can also do it, you know, at a micro level, and thinking about our institutions, thinking about the organizations that we work with. And we certainly have seen organizations step out in really bold and brave ways. You know, both the American Medical Association declaring racism as a public health crisis. We've seen this at local health departments across the city. We've seen institutions acknowledge the harm they have done to physicians of color. And I think there has to be that acknowledgement and ongoing assessment of those practices and policies. We've seen, you know, experts and equity leaders put out, you know, some really key pieces, you know, namely even our former Commissioner of Health, Dr. Mary Bassett, in a New England Journal of Medicine really talk about this and framing how structural racism not only shows up in our healthcare institutions, but also thinking about those policies and practices in thinking about housing and also mass incarceration or criminalization. And I think those are the conversations that we have to have within our institutions and organizations to really make sure that our ongoing work to dismantle structural racism is sustained. There are also sort of the infrastructure ways within the organization of having trainings. And I know, you know, there are amazing equity experts, you know, such as Dr. Uche Blackstock, who can be retained and, you know, really help think about ways in which you can do some of the anti-racist practice within organizations to normalize language and really talk about why structural racism doesn't even come up in your planning analysis, right? Like it exists in every part of our society, but no one is talking about it when you're thinking about how you're allocating your budget, how you're thinking about your workforce, and then how you're redirecting your resources. And so if you're not talking about it, then you are absolutely not addressing it. And certainly we know that silence is actually a perpetrator in sort of supporting how these structures continue to persist. So I think, you know, doing those trainings and investing in those trainings, but also really investing in those leaders and experts to really come in and think about how you are allocating resources and your work is really important as well. I think broadly the framing is really important to think about the opportunities for reinvestment. You know, as we do the dismantling work, as we really think about having the right language, a shared analysis, so that we can move forward, is also really thinking about where do you redirect your resources. And I think it's important to use sort of a shared analysis to think about, you know, not only your own resources, but how can we collectively identify what the problem is and come up with those solutions. And I think part of being creative, creating a collective strategy is having the right people with lived experience, people who are also thinking of and have been doing this work without the resources, right? In our community-based organization, very clear about the actors and, you know, sort of the leaders of this work. And so I think it's really important how you sort of define how you're getting the information and strategizing around this work. And so, you know, I think really broadening the analysis to make sure that those health outcomes, we're keeping it broad, right? Like, so thinking about how housing, we're addressing sort of housing instability, unhoused individuals. We're thinking about food systems and structures, thinking about how overcriminalizing plays into health outcomes, but keeping that that analysis and keeping that framing is really important as physician leaders. I mean, we have to understand where our patients are coming from and how they are presenting. And I think that we all play a part in really addressing those inequities.
You mentioned people standing on the sidelines. We always say that silence is complicity. So we have to make sure that we, as physicians, activists and leaders and advocates bring along those who just are standing on the sideline. A very important question just came up that I think we really need to address, and that is, wouldn't vaccines, like other healthcare interventions, be more accepted by patients if their physicians were giving it to them? In New York State, the physicians have been systematically excluded from having the vaccine supplies. Understand it when you have to do minus 100 degrees centigrade, 100 degrees Fahrenheit, and 73 degrees centigrade. It's understandable. Most people don't have the equipment to do that. But now that there are 2 vaccines out, that's not the case. Would you comment on the effect of getting more people over their hesitancy and improving their confidence if their physician was administering the vaccine? Anybody?
That's for me, right? Oh, anybody? Okay.
I feel like that's for, I feel like it's for Torian. I guess Torian can speak to what the city is going to be doing, but no, I think that's an excellent point that whoever asked that question brings up. I know Kaiser Family Foundation did a poll recently that showed that people are most likely to get their vaccine information from their physician or healthcare providers. And so I know that, Dr. Aletha Maybank, who used to be at the DOH, she's with American Medical Association now, and I know that they have been trying to advocate for, for private physicians to be able to vaccinate from their offices, and so I think that would be a huge, huge win. And so I'm curious what Dr. Easterling can share with us about what's the plans for New York City.
Yeah, I totally agree. And we've seen this data in a number of surveys, as Dr. Blackstock mentioned. Kaiser Family Foundation, their survey in our New York City Health Opinion Poll, and the first one that we did back in December, we knew even before the vaccine distribution ramp up really happened that majority of New Yorkers preferred to go to their providers. And certainly we saw this for older adults. So even with that information, really matching it up, right? So in the beginning, we didn't start off with older adults, right? And so really we're focusing on healthcare workers and also thinking about our congregate settings and long-term care facilities. And so really thinking about the infrastructure there. And as we continue to roll out, as you mentioned, there were limitations about where you could really place the vaccines and really the sort of thinking about the capacity of both being able to store, but also the capacity to be able to take on trays of vaccine. And so while we were, beginning the ramp up of the vaccine rollout, there has been ongoing engagement with physician groups to really, think about how we can support, physicians to really take on vaccines in their own office. Now, I think there are a number of different things that sort of may limit a small or medium-sized practice to really take on vaccines. Certainly, from the very beginning, the state was very clear that there was a pace goal in being able to use your vaccines and within after a week or face a penalty. And so, providers were very clear, and even some healthcare systems were very clear, like, we do not want to face that penalty. And if we cannot move the vaccine fast enough, then why are we going to take on that risk? Certainly, that is a concern for a medium-sized, small-based provider to really take that on from the very beginning. And so there has been a lot of education and outreach and technical assistance that our health department has been doing. Certainly our federally qualified health centers, really working with them, building up resources and capacity that they can take on, and giving the announcement from the federal government to allot more doses to our FQACs, as I mentioned earlier, was really, really important. So we're still doing that work. We are still identifying providers who are enrolling into our citywide immunization registry, really going through our checklist and seeing if those providers can really take on the vaccines, given some of the guidance that we know that the state has put out. So totally support, and we know that that is certainly something that we have to continue to do, is bring on more providers.
One of the questions that came through had to do with the approach to the elderly as well as homebound patients. So I don't know, not to put all the questions on you, Dr. Easterling, but any thoughts regarding what's the approach to those particular patient populations?
Homebound, our homebound individuals right now in New York City, there is a process. So you can just go on to our nyc.gov/COVID vaccine. There is a sign up process. So for any individual who's fully immobilized, homebound, regardless of age, if they're eligible for the vaccine, 18 years and older, they will receive a phone call, make sure that they're scheduled to receive a visit from a contracted vendor who can administer Johnson & Johnson vaccine. So that is something that we have in place in New York City. As far as our seniors, and we have been seeing this particularly over the last several weeks, that as the eligibility groups have expanded, we have been seeing less and less seniors getting vaccinated. Certainly it was really important, making sure that our seniors in January getting them vaccinated, whether through healthcare systems, whether through our city sites or pharmacies. But you've already heard, the governor has already expanded the eligibility to 30 years of age and older. And so certainly knowing that our seniors may not be as apt to getting on a website and making sure that they can schedule their appointments, we've had a call center, 877-VAX4-NYC, where they can call and make an appointment. And so here are the ways that we're really trying to support our seniors, and we continue to support our seniors, and that is our number one priority. Certainly, we're seeing the national average. New York City, we are below the national average as far as vaccinating or at least one dose and vaccinating our seniors. Certainly across the country, it varies when you look at fully vaccinated older adults. And I think that is also something that we're going to have to continue to watch. It's not just getting one dose, but also making sure that we're getting follow-up. And so from a supply, and so we're thinking about our allocation. You can either schedule on our website, or you can actually go to a call center. Through our call center, we're actually screening and making sure that anyone that is 65 and older is scheduled for an appointment. And there are ways in which we can really use our system to make sure that we're screening for 65 plus, to make sure that they are not being turned away and that they're being prioritized and getting an appointment. I've already mentioned we're working with our community-based organizations. And so that runs the gamut from Department for the Aging, Department of Youth and Child Development, Department of Health, community-based organizations. And so we've deployed community-based organizations and canvassers, some of whom are going door to door in New York City housing authorities and senior buildings, literally knocking on doors, signing people up who are 65 and older to get an appointment. And we've been doing that now for over a month and a half, working with NYCHA and some of our national occurring retirement communities to make sure that our seniors are getting vaccinated. We've actually located some of our pop-up sites in the community room at the senior building. So literally a person just has to come downstairs and get vaccinated. We still have more work to do. And so in some of the sites, we do have walk-ups for individuals who are 75 and older. Literally, they can just walk up at those sites. And we've been really messaging through our community-based organizations to know which sites that they can go to. We see this happening in some other jurisdictions. Boston is doing it, San Francisco, and also Philadelphia. And so, we know that there are some risks, right? We do not want our seniors waiting in long lines. We want them to be prioritized and just ushered right in and make sure that they're getting vaccinated as quickly as possible. They're not standing on their feet. And so certainly we want to make sure that we have this prepared so when our seniors are showing up. But and even we've been engaging our providers. I mean, we've been working with the NMA, Manhattan Central Medical Society, National Hispanic Medical Association, to make sure that we're reaching out to our physicians to say, do you have seniors that need to be vaccinated? How can we help you make sure that you're getting your seniors vaccinated? So there's a number of different pathways that we can really we are moving and trying to use social networks to really make sure that we're reaching out to seniors.
I just have one thing that I will say as we're about to wrap up. The name of the forum was Beyond Tuskegee. And when I was in practice, I said, if I had $1 for every time somebody said Tuskegee to me, I could be on an island someplace in, not Brazil right now, but anyway, on a tropical island. However, I want to just say about Beyond Tuskegee. Tuskegee went on from 1932 to 1972. And I always try to explain to my patients one-on-one, as I would do now, that it was a horrible thing. But if we let Tuskegee guide our every movement, other than being vigilant about what's going on, we're going to be victimized twice. COVID vaccines save lives. And I think we need to be sure that when we are talking about it, we understand people's fear of allergies. We understand their fear of being experimental or being guinea pigs, that we talk it through with them without judgment, but that we need to say, and I would say to my patients back then, it's what I would do for my parents. It's what now I would say, it's what I've done for myself. It's what I've done for the people that I care about, so that we don't persist in having the language that keeps them on the fence. Because when you say it to them, that's what I would do for myself. It's what I would do for my loved one. It carries a lot of weight. I just want to thank all of the panelists for all the wonderful work. Dr. Melniker, Dr. Smith, everybody who's participated, a great thank you, a debt of gratitude for all that you've done. And of course, my co-facilitator, Dr. Claire, thank you.
Thank you so much. And with that, we'll turn it back over to Dr. Moore to close out the program. And thanks again to Dr. Easterling, Dr. Villanueva, and Dr. Blackstock. Thank you so much. And my colleague, Dr. Sweeney.
Well, thank you all. A world of thanks to our wonderful moderators, Drs. Camille Clare and Dr. Monica Sweeney. I can't think of anyone who could have done a better job. I would like to thank our sponsors, the National Medical Association. Specifically, we are Region 1, the Northeast, but the entire NMA, and of course, my own organization here in Brooklyn, the Medical Society of the County of Kings. Our administrative director, Liz Harrison, and of course, this almost flawless presentation that you've seen is being manned by individuals, and from my other organization, Physician for National Health Program. So we have both Mandy and Morgan, who obviously know how to do this and have done a wonderful job at it. But most importantly, I'd like to thank you, the audience, the hundreds of folks that have joined us at this meeting that basically has promoted this idea that we need to have a forum, a discussion. We need to discuss vaccines. We need to discuss what are the issues to get the vaccines distributed equitably and to get the vaccines distributed, period. So again, I'd like to thank our most distinguished panelists, this august group of physicians, and of course, our wonderful audience. We look forward to another event like this in the next 3 months. Thank you.